Management of the patient with severe Charcot-arthropathy, also known as Charcot foot, is notoriously difficult. The pathophysiology of Charcot foot is poorly understood, but is often attributed to neurotraumatic joint destruction secondary to a loss of protective sensation or neurovascular changes from autonomic dysfunction and abnormal bone resorption. As a result, the normal plantigrade architecture of the midfoot and hindfoot are lost, causing deformity that can predispose patients to ulceration and infection, inability to bear weight, and overall loss of function. Charcot-arthropathy occurs in approximately 1 to 1.5% of patients with diabetes and in 7.5% of patients with diabetes and underlying neuropathy. The diagnosis of Charcot foot can be established with plain film imaging of the foot and ankle as well as clinical examination. Imaging often reveals obliteration of joint spaces and fragmentation of articular surfaces. Clinically, these patients will often appear as though they have an underlying infection such as cellulitis or osteomyelitis. The current treatment of Charcot-arthropathy is focused on deformity correction and attempting to salvage the affected limb. In patients with a deformity that may be amenable to bracing, surgery is often deferred. However, in patients with significant bony prominences that may cause pressure ulceration, resection of these bony deformities is often required via exostectomy. In patients with a more advanced deformity, correction is often required with arthrodesis of the involved joints, with or without osteotomies to correct other deformities. The salvage procedure for those with end-stage Charcot-arthropathy is often a below-knee amputation. There are many studies that have been conducted regarding surgical management of the foot and ankle in the setting of Charcot-arthropathy. However, there is little in the order of outcomes of surgical options, and minimal research comparing various reconstructive options. This project aims to analyze Charcot hindfoot and ankle reconstruction utilizing tibio-calcaneal fusion with total talectomy compared with the standard tibio-talo-calcaneal fusion. Due to the novelty of talectomy as a supplement to fusion, little data exists to substantiate its efficacy. Nonetheless, we hypothesize that, compared to standard tibio-talo-calcaneal fusion, tibio-calcaneal fusion with total talectomy will decrease complication rates, increase quality of life, and increase overall patient satisfaction. Retrospective chart review was used to identify patients and rates of complication including recurrent ulceration, progression of deformity, and need for revision surgery. Additionally, patients were contacted to obtain subjective data including functional outcome scores, pain scales, and overall satisfaction scores. This data will then be compared to that of standard fusion to determine the best technique for Charcot foot, hindfoot, and ankle reconstruction that minimizes complications and provides the best outcomes. Patient satisfaction is the main purpose of reconstruction. Therefore, this research will serve to find the best technique for deformity correction and limb salvage. This exploration of surgical outcomes may also open the door to new surgical techniques and treatment options not yet explored by the orthopedic community. Preliminary data shows that, of the 6 patients who underwent tibio-calcaneal fusion with total talectomy, 5 successfully achieved limb salvage. The remaining 1 patient underwent a below-knee amputation. Post-operative complications were present in all patients. However, the comparison to those undergoing the standard tibio-talo-calcaneal fusion is yet to be determined. FAOS Pro Score survey collection is also ongoing and will be completed shortly. This project will continue for years to come as we work to expand our cohort of surgical participants with the goal of building a more statistically significant data set that may serve to further emphasize the efficacy of this surgical method compared to the standard fusion method utilized today. I'd also like to thank the Department of Orthopedic Surgery at Frederick Hospital, along with Dr. Brian Law and Dr. Andrew Valaket for their support of this work.